Hello, everyone, and welcome. My name is Dr. Esther Freeman, and I'm the Director of Global Health Dermatology here at Massachusetts General Hospital, Harvard Medical School, and I'm also the Vice Chair of the International Foundation for Dermatology. I'm so pleased to be with you today to welcome you to today's global webinar, and thank you so much for joining us from across the world. Today is special because this is in honor of World AIDS Day, which is a moment each year in December where we recommit ourselves to the global fight against HIV and to improving the lives of those affected by this virus around the world, and also to how we can advance equity in access to care. World AIDS Day calls us to reflect, but it also calls us to act. And we're really having this webinar today in the spirit of that action. So we've organized today's session to be focused, really practical, and firmly grounded in the realities of practicing clinical dermatology worldwide. So while HIV remains at the heart of our program on this World AIDS Day, we've also broadened our lens to include other pressing infectious diseases that are relevant to today's world and how they intersect with dermatologic care. From the resistance of drug-resistant dermatophytes, which is really a pressing issue worldwide, also to the evolving epidemiology of Mpox, which we've seen grow in the last few years and continues to be an outbreak and epidemic that has not gone away. So today's talks will really highlight timely issues within the landscape of infectious disease dermatology worldwide. I do want to take a moment to acknowledge the International League of Dermatologic Societies, which is hosting today's webinar. As many of you know, the ILDS represents a global organization that is a meta-society of societies, and we work together through education, advocacy, and partnerships, and I'm certainly a proud member and representative of the ILDS. And we're particularly focused and committed to ensuring that advances translate to our resource underserved countries around the world. And I hope that today's webinar can continue to share knowledge that can make a difference for our patients wherever you're located. We're really fortunate to have three outstanding speakers today who span the work from clinical care through research and to public health across three different, very diverse global contexts. So our first speaker is Dr. Adam Lipworth, who is my friend and colleague who hails right here from Boston, Massachusetts, where he's the department chair at the Leahy Hospital and is a Harvard Medical School assistant professor. So he received his training from University of Pennsylvania before training at Harvard, and he currently has extensive experience working in underserved communities, both locally and internationally, including in South Africa, Botswana, and the Navajo Nation program in New Mexico, as well as locally at the Boston Healthcare for the Homeless program. And his practice at Leahy focuses on multidisciplinary care of patients with primary cutaneous infections or systemic infections, including the skin. So his talk will be on IRIS essentials for the dermatologist. And for those of you who are not familiar with IRIS, IRIS is immune reconstitution inflammatory syndrome, an area that remains central to HIV care, but is still under-recognized in dermatology practice. I always learn a lot from Dr. Lipworth, and I'm sure you will as well. Next, we'll be hearing from Dr. Ananta Khurana, who's based in India. She's a professor in the Department of Dermatology, Venerology, and Leprosy at RML Hospital in New Delhi, India. Dr. Khurana is really a leader in this field in terms of drug-resistant dermatophytes and has done pioneering work on T. inditinae infections since 2018, really the early emergence of this infection, and has over 123 scientific publications to her credit. She's also authored 5 books, including the IADVL Manual on the Management of Dermatophytosis. So her session today on drug-resistant dermatophytes is really going to provide critical updates on diagnosis, treatment strategies, and resistant patterns that clinicians really need to know as these infections become increasingly common worldwide. And I can say in my own practice, both in the United States and internationally, we've really seen an increase in the last few years in terms of drug-resistant dermatophytes. Our third and final speaker is my colleague, Dr. Doriane Sabushimike, who hails from Burundi. Dr. Sabushimike is a dermatologist who trained in both Rwanda and Tanzania and has returned home to her native Burundi, where she is leading research and clinical work on HIV and at the intersection of Mpox, which is having a significant outbreak in Burundi and neighboring areas, including the Democratic Republic of Congo. I think it's important for us to recognize that Mpox hasn't gone away, even though the global overall epidemic has somewhat slowed, but it's still present and still an important and emerging issue. So she'll be talking about what the dermatology community needs to be prepared for the coming years and the latest that we know around HIV and Mpox. So after these talks, we'll be switching over to a live Q&A session where you can be asking moderators questions through a live chat, and you can encourage you to submit your questions throughout the session so that we can discuss them in real time at the end. So with that, we are going to begin, and it's my absolute pleasure to ask our first speaker, Dr. Lipworth, to start us off.
Hello and welcome. My name is Adam Lipworth. I am the Chair of Dermatology at the Leahy Hospital and Medical Center, just north of Boston, and I will be presenting to you on IRIS, the Immune Reconstitution Inflammatory Syndrome, Essentials for the Dermatologist. And these slides come from my time both in Boston, but also in Southern Africa, in South Africa and Botswana. So I'm going to show you pictures in just a moment of a patient from Durban, South Africa, 44-year-old man who presented with a low CD4 count, about 90. And this is what his leg looked like. He had these diffuse nodules and plaques all over. These are not bulli. They might look like bulli. They were not filled with fluid. They were firm nodules and tumors. You can see they're on both of his lower extremities. And if you look closely, it might start to look a little bit less overwhelming. You can see that violaceous to red-brown color that is so characteristic of Kaposi sarcoma. And that's what this is, these violaceous plaques and nodules and tumors of advanced Kaposi sarcoma in AIDS. These nodules were rapidly progressive over about 2 months. And that rapid progression began about 3 months after starting antiretroviral therapy. That's because this was Kaposi sarcoma presenting as part of IRIS, the Immune Reconstitution Inflammatory Syndrome, which is seen fairly frequently in patients with poor immune systems, generally low CD4 counts, who start antiretroviral therapy. And as their immune reconstitutes, they can develop unusual signs and symptoms that we will discuss. So Kaposi sarcoma is one of the most commonly reported underlying conditions that can flare or emerge as part of the immune reconstitution inflammatory syndrome. Now, what is IRIS? Here are the key elements. It is a worsening or unmasking of a pre-existing disease process with immune recovery from antiretroviral therapy. Okay? A few elements here, let's break it down a little bit. Worsening or unmasking. So worsening would be you have a condition, it is manifest, you can see it, such as Kaposi sarcoma on this leg to the left. You start antiretroviral therapy and it worsens. And that is called paradoxical IRIS, because if you didn't know of its existence, you might find it paradoxical that they worsened instead of getting better after starting immune reconstitution therapy. Unmasking IRIS is when you have a condition, but it is not manifest. You don't have symptoms or signs of it outwardly. You start antiretroviral therapy and the condition becomes unmasked. You can see it emerge for the first time. It's not that it developed after starting antiretroviral therapy. It already was there before, but it was not clinically apparent until after starting the antiretroviral therapy. Okay, so paradoxical IRIS and unmasking IRIS, the two forms of IRIS. Now, do we as dermatologists really need to know about cutaneous forms of IRIS? Well, let's look at this list again. These are the most commonly reported underlying conditions that can worsen or emerge as part of IRIS. And if you look through this list, you might notice that all of them, well, almost all of them, all but two, either can occur on the skin or predominantly do occur on the skin. And in fact, more than 50% of IRIS events are dermatologic, and there are some nice papers showing that they are often of atypical morphology and histology. So you can't trust your eyes as much as you normally would to make a diagnosis morphologically, and you can't trust your pathologist as much as you normally would to look at the histology and make a diagnosis. They are atypical and they are tricky to diagnose. And these are the most commonly reported conditions as part of IRIS. For reasons I don't fully understand, there are a whole host of other conditions in the literature that just never, by historical accident, got lumped together under this heading of IRIS. Here's a classic example. This patient has these pruritic acneiform papules all over her face. And this is eosinophilic folliculitis, which oftentimes emerges in the weeks and months after starting antiretrovirals. And in many ways, it is a quintessential classic form of IRIS. And yet in the literature, it's always just referred to as eosinophilic folliculitis, and sometimes it gets mentioned that it often happens after starting antiretrovirals, but it's not lumped together with IRIS when reporting incidences and prevalences for some reason. And there's a whole host of other ones that, again, get reported as worsening after starting antiretrovirals, but don't get lumped in the papers that are reporting incidences and prevalences of IRIS for some reason that I don't fully understand. And this list is not comprehensive. It gets much longer than this. Almost anything on the skin has been reported to worsen or emerge as part of IRIS. And the incidence of IRIS remains a problem. This was a nice recent 2020 prospective trial, US, Kenya, and Thailand. They took 506 patients, all with CD4 counts below 100, and found that within 6 months, almost 20% of them developed IRIS, 19.2%. Now, you might say that the incidence of CD4 counts below 100 is going down quite rapidly, and thankfully that is true. But while most countries don't report the prevalence of advanced HIV disease, the WHO does report the incidence of HIV-related deaths, and in 2024 that was 630,000. It is easy to infer that the prevalence of advanced HIV disease must be substantially higher than that rate of death. So we're talking about many hundreds of thousands, likely millions of people who are at least at risk for developing IRIS when starting antiretrovirals. In the US, we do actually have data on the new classification of stage 3 HIV disease, of advanced HIV disease as defined by the CDC. In each year. And in 2023, 17,500 patients were diagnosed newly with stage 3 HIV disease, CDC criteria. So advanced HIV disease, that's quite a large number. Now, you might say, compared to a country of 340 million, the US, 17,000 and 17,500 is not very big. But the group of dermatologists who are watching this webinar right now is also not a random sampling of dermatologists. And I would posit that if you are watching this video right now, there's a decent chance that when one of the hundreds of patients in your city, if you live in a city who develops IRIS each year, that there's a decent chance that they will be filtered to your clinic at some point. That at least some of them will find their way to your clinic because you have an interest in HIV dermatology, or you wouldn't be watching this webinar. So that 17,500 is actually not such a small number for those of us who specialize in this condition. It means that we will see these patients on a regular basis for the foreseeable future. So the key points so far: number one, IRIS incidence remains a problem. Number two, almost any derm condition can emerge or worsen as part of IRIS. And number three, the presentations are often atypical both morphologically and histologically. They are tough to diagnose. But we often treat these skin diseases the same, whether or not they're presenting as part of IRIS. Somebody presents with seborrheic dermatitis, you treat them for seborrheic dermatitis, whether their sebderm is related to IRIS or not. If they have zoster, you treat them for zoster, right? We treat them the same, mostly. So, again, I ask, why do we need to know about cutaneous IRIS? That question from the beginning. So to answer this important question, I'm going to show you another patient. This is a young woman I met in Boston a number of years ago now. And you can see these papules all over her face with little umbilications and a little white dell at the base, a little white core at the base of each of these umbilications. And this is molluscum, facial molluscum in a patient with advanced HIV disease. She was 34 in Boston. She had HIV, several comorbidities, including hepatitis C and cirrhosis. CD4 count was consistently less than 20, both because of her medical comorbidities and because of social barriers to care. She would go on and off of her antiretroviral therapy quite frequently. And she had these molluscum, but interestingly, these molluscum would only appear 1 or 2 months after starting her antiretroviral therapy each time. And then when she would come off of her antiretroviral therapy for one reason or another, sometimes because of the molluscum themselves, the molluscum would go away. So this was molluscum presenting as part of iris. So in some ways, it's interesting. You could say that her molluscum is a sign of adherence. Simple, right? You're taking your meds. These are the molluscum that are developing. Maybe if it's even encouraging, right? Congratulations, thank you for taking your medications. Let's push through. You'll get through to the other side. Your health will improve. The molluscum will go away, right? So maybe even encouraging. But of course, I wouldn't be presenting it like this if it were indeed that simple, and it was not. So these molluscum were not the only things she would develop as part of iris, or at least in the months after starting antiretroviral therapy. When she would develop these molluscum, she would also typically develop these plaques and vesicles on the soles of her feet. And in the background of those molluscum, notice those red-brown dermal plaques on her face and on her upper extremities, very well demarcated, red-brown dermal plaques. She developed this ulcer on the same spot on her scalp each time, consistently negative for HSV, VZV, and CMV. We did PCRs, DFAs, zinc preps, and biopsies for stains, consistently negative. She also developed these angulated, well-demarcated ulcers and erosions on her buttocks, again, negative for HSV, VZV, CMV, for anything we could look for. In addition to those plaques on her soles, she developed these pernio-like, purpuric papules on her toes. I'm not going to go into detail about the pathology. We had a ton of biopsies. I will tell you, all of the pathology was very mixed, lymphocytic, eosinophilic, oftentimes mixed with some neutrophils as well, deep, superficial. Almost every pattern that I've seen in pathology occurred in these biopsies, and oftentimes the biopsy of a red-brown dermal plaque would look similar to the biopsy of the edge of one of these ulcers on her buttock. Very difficult to make a clear and compelling story out of her pathology. So, is this all iris? If so, what are the underlying conditions or condition? Maybe some of these or all of them are adverse drug reactions, maybe even to the antiretrovirals themselves. Or maybe she's got new infections, like, if HSV and VZV and CMV are negative, maybe there's some other infection causing these ulcers, for example. Or maybe they're worsening infections that she already had because of non-adherence, not because of iris, just the opposite. We think she's taking her meds and she's getting molluscum because of it, because of iris, but maybe she's actually not being adherent and now she's getting worsening of infections because of that. Precisely the opposite scenario of what we expect. We think of iris as this relatively straightforward model, right? You have, let's say, a pathogen, and then you start taking antiretroviral therapy. It creates a host immune response to that pathogen, which creates a symptom or sign or a multitude of symptoms and signs, a presentation. Okay, relatively simple and straightforward. But sometimes stopping the antiretrovirals and allowing the host immune response to decline can allow that pathogen to create that exact same symptom or sign that you can see when the immune response increases. Sometimes new infections can cause that same sign or symptom, that same presentation. Or maybe not infectious. Maybe it's a new autoimmune condition that's flaring and that can create that same sign or symptom, that same presentation. Or maybe a direct drug effect, including from the antiretrovirals themselves. And these patients with CD4 counts of 10, 20, 30, 50, 100, they're on many other drugs as well, all of which can cause side effects which may look the same. Now we've got a pretty messy model, right? And in this entire model, iris is just one path to get to that observed sign or symptom that we're hanging our hat on. And these patients with very low CD4 counts presenting with potential iris, they don't have just one sign or symptom that's unusual. They often present with many, each with its own overlapping model. And now you can see just what a mess iris can become in real life. That simple-ish model becomes very confusing when you're faced with an actual patient with many of these signs and symptoms happening at the same time. Now, I did mention the management of cutaneous iris is relatively straightforward. You treat the underlying condition and its symptoms the same as you would if they were presenting without iris. Sometimes you add NSAIDs to the mix, non-steroidal anti-inflammatory drugs, sometimes systemic steroids if it's very severe, and very rarely, especially for us in dermatology, very rare, would you have to withdraw antiretroviral therapy. That's generally done, first of all, in conjunction with the ID doctors, and usually for types of iris that have higher mortality, like meningococcemia and sometimes tuberculosis. But I would argue that the key step in management is simply making the diagnosis of iris. Iris falls through the cracks. Cutaneous iris in particular falls through the cracks. ID doctors know iris well, but they don't know the skin nearly as well as dermatologists do. Dermatologists know the skin well, but we don't know iris as well as the ID docs do, and patients can fall through the cracks between our two specialties. If you consider the possibility of iris in a patient presenting with an unusual sign or symptom or multitude of signs and symptoms in the weeks and months after starting antiretroviral therapy, you can avoid unnecessary invasive tests for that patient. You can avoid unnecessary termination or modification of their antiretroviral therapy regimen. And you can sometimes identify systemic diseases that are emerging on the skin, oftentimes in dramatic form because of iris. You can make a huge difference for your patients simply by considering the diagnosis of iris and communicating that consideration to the rest of the patient's team. So that is my plea and my urge. I will urge everybody to please consider iris in any unusual cutaneous presentation in the months after antiretroviral therapy commencement. And at that point, even if you're not sure what to do, discussing it with anybody else on that patient's team can often lead to a better outcome than if it goes unnoticed in the first place. I thank you very much for your attention. I thank my many mentors, and I thank my patients for allowing me to photograph their skin for the benefit of others. Thank you very much.
Hello all, I am Dr. Ananta Khurana from RML Hospital, New Delhi, India, and I shall be talking about drug-resistant dermatophytosis today. I have no financial disclosures or conflicts of interest to declare. So let's talk about antifungal resistance per se. So when we talk about antimicrobial resistance, antifungal resistance has taken a backseat amongst the whole AMR programs. So to define, antifungal resistance can be intrinsic, as in you acquire an organism which is already resistant to some particular drugs, or it can be acquired under drug pressure. So it was only recently that antifungal sensitivity has also been given importance in the AMR programs worldwide, and considering the importance of fungal infection in humans. So talking of the resistance mechanism, I shall especially be focusing on Trichophyton endotenae, the new organism, the new species which has come up across the world causing treatment recalcitrant tinea corporis, cruris, and fasciae. So since 2016-17, it was noticed that there has been a change in the scenario of dermatophytosis, and it was not initially understood why this was happening, and there had been reviews written and commentaries about why the shift was being seen. And it was thought that possibly that is something to do with the organism having required resistance to the first line agent, which was terbinafine at that point of time. So to understand antifungal resistance in dermatophytes, remember this diagram. This is where the most of the drugs which act on dermatophytes act. So this is the ergosterol synthesis pathway. Ergosterol is a very essential component of fungal cell membranes, and it also has certain effects on the cell division. So azoles and allylamines, the two major classes of drugs we have against dermatophytes, both act at the two stops over this pathway, lanosterol demethylase where azoles act, and squalene epoxidase where allylamines act. So all the resistance mechanisms, the known and the possible resistance mechanism, which are largely focused on these particular steps in the ergosterol synthesis pathway. So one resistance mechanism which has come up and has been proven is the mutations in the target genes or amplification of the target genes. So again, coming back to this pathway, squalene epoxidase, which is encoded by ERG1 gene, that is a step where we know mutations exist and they have been documented in various studies, although the others downstream of squalene epoxidase, the mutations are less well documented and understood. So squalene epoxidase is a protein where terbinafine acts to affect its response within the organism. Squalene epoxidase is encoded by a ERG1 gene. So going back in history, the first report of terbinafine resistance in dermatophytes actually came in early 2000s. This was in 2003, where some resistance was noted in isolates from onychomycosis patient. So later it was documented that the cause of non-responsiveness of terbinafine in this particular patient was an altered squalene epoxidase protein. And later it was characterized that this was because of a single gene substitution in the squalene epoxidase, single amino acid substitution in the SQLE protein, which was caused by a single amino substitution in the SQLE gene, which is ERG1. So based on that, it was concluded that because this particular mechanism of a single gene substitution happening in the SQLE gene would be a very uncommon scenario. So dermatophytes, and it was Trichophyton rubrum at that time, does not have much ability to inherit terbinafine resistance. But that was then, and this is now. For post 2017, a shift was noticed where there was increasing dermatophyte resistance to terbinafine, reported first from India and then other countries of Middle East and elsewhere. And now this has been reported from almost every continent across the world. So SQLE mutations, which are most commonly reported in endotheliae, are the most important one is the substitution at 397 position from phenylalanine to leucine. This has been reported in more than 95% of the isolates across various studies, and this leads to a high level of terbinafine resistance. And this has been demonstrated not just in endotheliae, but initially it was demonstrated also in Trichophyton rubrum. And then it was subsequently shown that this particular mutation alters the SQLE protein, and this is transmittable to further transformants. They're also expressing the wild type SQLE proteins can carry on this to the next generation also. So it's something which is going on from one to another after cell division also. And then it was shown that this particular mutation affects the terbinafine binding site of SQLE, and hence it leads to a lower action of terbinafine. And there is cross resistance to other allylamines as well. So ERG1 gene altering the SQLE protein, leading to a lowered action of terbinafine. Other mutations have also been reported in the ergosterol synthetic pathways. There have been occasional reports of mutations in ERG3, 4, 11, and then in some of the efflux pump genes also. But their association with causing an increased MIC2 azole drugs has not been documented as yet, and the clinical relevance is also not as clear as is of SQLE gene mutations. So also know that when ERG11 is mutated, ERG11 is encodes for lanosterol demethylase, which is the enzyme where the azoles act. So just a mutation of ERG11 may not be enough to make the organism resistant, because there is an alternate pathway which then comes into action, which leads to formation of a fungistatic molecule called dienol, and that also can lead to a suppression of growth of the organism. So this is well known in Candida albicans, but possibly something like that also happens in dermatophytes. So azole resistance is more complex and not clearly defined yet. So there have been other mechanisms. The CYP51B gene, this is the gene which encodes for lanosterol demethylase. Missense mutations within this gene has been described in Trichophyton endotheliae, but it was shown that this particular mutation did not really affect itraconazole or voriconazole susceptibility, and instead it was an overexpression of this gene which could lead to a lower susceptibility to azole compounds. Now, another mechanism is efflux pumps. So it has been thought that some form of efflux pumps are active in dermatophytes. It was thought in probably 1990s, but much later it was demonstrated that dermatophytes do have ABC transporters or the efflux pumps. And much later it was shown that Trichophyton rubrum has certain efflux pumps, but the exact relevance of them in the pathogenesis of dermatophytes remains elusive. In the recent scenario, some studies have focused on efflux pumps, and there was this paper by Yamada et al., the same as I quoted before, but they also looked at the MDR3, which is a efflux pump within Trichophyton indotinea, but they observed only small differences in susceptibility to azoles when MDR3 was disrupted or when it was regularly expressed. So it wasn't clear whether this really contributes to azole resistance. Then there was another, this is a study from our center where ABC transporter superfamily MDR1 and MFS1's gene were found to be resistant to be disrupted in certain treatment recalcitrant cases, the isolates from them. But interestingly, these isolates were susceptible to itraconazole in vitro, although they were resistant to terbinafine, voriconazole, and fluconazole. So again, the relevance could not be really brought out as for azole resistance caused by flux pumps. Then stress responses, this is another mechanism implicated, but again, not much literature here. Biofilms, considering the high degree of relapses which we see in dermatophytosis, possibly biofilms have some role to play there and more research is required for this. But all said and done, what the clinicians need to know about this new organism and about resistant dermatophytosis is what is of most relevance to us. So I shall be focusing on that. First, the clinical presentation and then the treatment. So Trichophyton indotineae can present as localized disease, or it can be a very diffuse widespread disease and even erythrodermic presentations. So most often what we see is very non-inflammatory sort of a picture where there will be some scaling, no clear annular lesions may be visible. The central clearing may or may not be apparent. There might be pigmentation, especially in those who are highly pigmented. And there is often a very prominent involvement of the head and neck, of the face and neck, which goes on into the scalp without any obvious tinea capitis or invasion of the hairs occurring. Then there can be very mildly scaly lesions and they can be barely perceptible, especially in the darker skin types. There may be extensive involvement, the intramammary regions, the genital folds are often involved. And this is how a scalp involvement in bald or otherwise it can present on the scalp without invading the hair. And there are the youngest of infants, we have seen tinea corporis, faciae, and cruris developing in recent times, and often there is a family history in one of the caregivers here. So managing tinea in the era of Trichophyton indotineae, so considering that at least in our center, about 80% of the infections currently are caused by Trichophyton indotineae. So we taken it as granted that most of the infections which we are dealing with now, though sequencing culture is not possible in every case, but going by studies and data, most of the infections we deal with now are Trichophyton indotineae infections. So pointers for clinicians, we should remember that in the current scenario, terbinafine's efficacy has definitely lowered compared to the past, and itraconazole is the most effective drug currently. We did a RCT comparing the various doses of itraconazole 100, 200, and 400, and we found a high overall cure rate of 92.06%. And an interesting observation was that there was no difference in the cure rates between 100 and 200 mg doses. So there's a trend to use higher doses of itraconazole, but it is not much supported by literature. So 100 to 200 mg per day achieves high cure, and the both doses suffice and do not have much statistically significant difference between the cure rates, and beyond a dose of 200 mg is not really required routinely. Coming to the durations, so the durations are widely variable. Itraconazole may take between 2 to 20 weeks in different patients to achieve cure with a mean of 6.6 weeks. Again, here there is no clear difference, no statistical difference in the duration of treatment required to achieve cure between 100 and 200 mg, both taking about between 7 to 8 weeks to achieve cure. So treatment durations are widely variable, mean around 6 to 7 weeks or more, but it is a good idea to treat every patient till cure since we cannot define treatment durations for everyone. Again, cost effectiveness becomes an important issue because these infections now take very long to be cured, and then there is an issue of relapses where patients would require retreatment. So here we did a cost effective analysis and we found that to achieve the endpoint of cure, 100 mg is the most cost effective dose. Safety profile, although most of the side effects do not require treatment discontinuation, GI side effects can be bothersome and they are more with increasing doses. So again, another point in favor of using, not going beyond 100 to 200 mg per day. Suba-itraconazole has certain pharmacokinetic advantages, like itraconazole has a very variable absorption profile, inter-patient variability in absorption. So if available, Suba-itraconazole offers pharmacokinetic advantages and can be used. Terbinafine is an effective second-line option. It has advantages in terms of low pharmacokinetic interactions, efficacy, which is moderate, not as high it used to be, and a good safety profile. So although SQLE gene mutations have been described with terbinafine, it works well. And we found in this study that the odds of achieving cure with terbinafine in organisms which have MIC less than 1 microgram per ml are 2.5 times higher than the odds of achieving those in those with have a higher MICs. And overall, a 70% cure rate was achieved with increasing the duration of terbinafine or increasing the dose to 250 mg/d. So 250 mg/d is the standard dose we use for trichophytoneodynia infections now. So this diagram, this is the results of that study depicting how many of the patients who had SQLE protein substitutions also did respond well. And with increasing mean MICs, the dose duration of terbinafine had to be increased to achieve a cure. And another study which draws the same conclusion that prolonged treatments both with terbinafine and itraconazole help in achieving a higher cure rate. So prolonged treatment is required no matter whether we're using itraconazole or terbinafine. Fluconazole and greaseprevir have limited efficacy. We do not use those much in our practice now. Voriconazole we have occasionally used. There are some studies which but have not really brought out any great difference between the efficacy of voriconazole and itraconazole, so not much role of voriconazole there. Then antifungal combination, systemic antifungal combinations are often thought about that they could be used if there is increasing treatment recalcitrant. So although there are in vivo studies which suggest synergistic interactions between various antifungals, the clinical studies do not show that there is any advantage of using itraconazole and terbinafine together over using itraconazole alone. That does not add to the cure rates. So voriconizole's efficacy is not very impressive yet. The pharmacokinetic interactions, the narrow therapeutic window has to be considered, and the combinations of systemic agents do not seem to provide any advantage over itraconazole monotherapy. They can add to the spectrum of adverse effects, to the cost, of course. And then topical antifungal combinations with systemic, also we have to consider that the body surface area involvement may be pretty high in many trichophytoneodynia infections. So the logistics and the cost of adding a topical antifungal, and that's how you choose which topical antifungal to add. So that has to be borne in mind also. With extensive infection, patient may not be able to apply topical antifungals all through. And a study from India had shown that adding luliconazole to itraconazole does not increase the cure rates of itraconazole beyond what itraconazole achieves alone. It may be different for other drugs which have a lower efficacy like terbinafine, but it is yet to be proven in studies. About relapses, the relapses are consistently high across all drugs. So either treated with terbinafine, itraconazole, or ketoconazole, the relapses remain high. And even after ensuring good compliance and provision of drugs, we noticed high relapse rates in all itraconazole dosing groups in our RCT. And interestingly, there was no significant difference in relapse rates between any of the three doses. And the duration of treatment, the extent of infection also does not seem to affect relapses. So possibly it is some intrinsic mechanism of trichophytoneodynia which results in so many relapses. But this is a very bothersome thing in trichophytoneodynia infections, both for the clinicians and patients. So the cause is really not known, but clinical experience suggests a relapse per se is not an indication to change the antifungal drugs. The patients do respond to the same antifungal given the second or third time over also, with similar durations and similar efficacy. So just to conclude, take-home points, prolonged treatment is essential for drug-resistant trichophytoneodynia infection, 50% of the patients to experience. These are the recent review articles we have written on this topic, and you could please refer to them for any further details. Thank you so much.
Hi everyone, my name is Doriane Sabushimike. I'm a consultant dermatologist from Burundi, currently working at Kamenge Military Hospital where I lead the Mpox management unit in the hospital. And it's an honor and a pleasure to be invited today to talk about Mpox and HIV clinical overlap, a subject that remained very relevant, especially in the African concept. So this is how we structured my talk. I will start with a brief introduction about Mpox, talk a little bit about the clades, transmission route, and clinical signs. I am trying to compare the signs in immunocompetent and immunosuppressed patients. And then I'll talk a little bit about the global epidemiological situation with a focus on the situation in Africa, and then take you through a case report of Mpox and HIV co-infection that we published from Burundi, and touch a little bit about the management of Mpox immunosuppressed patients and the usage of tecovirimat management of these patients. Now, end this with a take-home message. So, Mpox is belongs to the Orthopoxviridae family and has two main clades, clade 1 and 2, which I'm going to talk about later in the presentation. And it has double-stranded DNA virus. It's a double-stranded DNA virus capable of infecting both human and animals. And when the WHO declared the global outbreak in July 2022, something striking happened. And this was the fact that 50% of the reported cases occurred in people having HIV. And you understand, these dramatically influence the way the disease is managed and the outcome. And this is the reason why we're discussing this today. So now coming back to the clades, as I said, it has two main clades, clade 1 and clade 2. And as you know, clade are just genetic branches of viruses that result from the changes in the replication of the virus in different regions, geographic region. It is associated with different maybe severity, manifestation, and outcome. So when it comes to Mpox, the main one are clade 1 and 2. And clade 1 is the one that was formerly found in the Congo Basin and it was associated with high fatality rate. Now it has a subclass, which is 1B, which is remarkable, associated with human-to-human transmission in a short period and had been spreading through sexual intercourse. And when it comes to clade 2, which was formerly in the West African clade and associated with lower fatality rate, is the one that caused the WHO to declare a global outbreak in 2022 and is associated with transmission into the developed countries from travelers. So when it comes to transmission now, Mpox is not to be transmitted human to human and by close contact, skin to skin, through the skin lesions. When you touch a skin, an infected lesion, and you have a small breakage of your skin, that's how you get it. But it can be also transmitted via respiratory droplets, contaminated bedding with the blankets. We used to say probably via sex, but now we know, yes, it can be transmitted via sexual intercourse and can be also transmitted from mother to a child congenitally. So now in the African context, we still have as well mixed transmission such as zoonotic transmission from primates, contact with not human primates, but also by consuming raw meat from infected animals or the bites from the rodents. And we still have community transmission as well and household transmission in the African context. So now when it comes to signs and symptoms of Mpox, I will try to compare and contrast the manifestation in immunocompetent patient and immunosuppressed patient with HIV. So generally, after being exposed to the virus, 3 to 21 days, an immunocompetent patient will develop the first signs. And sometimes it can start with the prodromal symptoms such as a fever, headaches, and fatigue, or just straight with the skin lesions on the site of contact. And these usually start as vesicles that evolve into small papules that are umbilicated and ulcerate, leaving crust. And it's when the crust falls that we know the patient is not contagious anymore. And these lesions can appear anywhere on the skin, including the mucosa as well. And when it comes to immunocompromised patients, the lesions, first of all, before I go to this, I want to mention that these lesions usually stays 1 to 2 weeks only, and it's self-limited in an immunocompetent patient. But now when it comes to patient with HIV, these lesions tend to stay longer, and instead of just developing crusts, they would tend to have necrosis, central necrosis instead of umbilication. And also they might evolve into pseudogangrenous lesions, very big and painful ulcers as well that take longer to heal compared to patients who are immunocompetent. So this is a table that compare the management, the presentation in immunocompetent and immunosuppressed with HIV. But what I want you to keep in mind is that, first of all, the patients who are immunosuppressed present with more severe systemic symptoms, such as the fatigue is profound and higher fever compared to the immunocompetent patient, with a risk of sepsis. The lesions, as I say, they persist much longer, and then instead of just being localized where the contact has been, they tend to be more widespread, and they tend to have to be necrotic and coalescing to pseudogangrenous lesions, and we have more chances of complicating into septicemia, secondary infections, dehydration, and prolonged hospitalization due to septicemia. So it comes now to global distribution of the Mpox according to clades. First of all, you should know it's not because we have few cases that are being reported that the outbreak is over. It's not over. And this is a global map that shows the distribution of clades, of Mpox according to clades. And this was, it shows from January 2022 to July 2025. As what is standing out is how the clade 2, clade 2 has been widely spread in the world, and this is explained by the transmission via international travelings, and in contrast with the clade 1, especially 1b, that has been remained in West, Central and East Africa. And now the current situation in Africa until July 2025, as you all know, the epicenter of Mpox is in the Republic of Congo, where we have a lot of cases. So in general, in Africa, we had around so far, up to July 2025, we had up to 25,000 cases of Mpox, with around 100 deaths, and more than 80% of those deaths occurring in the DRC. To make it more clear, looking at this graph, you see that most of the cases up to July, we were having cases from Congo. Few cases in Burundi. See that we have started to having fewer cases, but we still have cases. But then some cases that started to appear in Uganda from October 2024, and fewer now in July, and some new cases that happened earlier this year in May from Sierra Leone. So you see, according to this chart, that we still have new cases occurring in Africa. Now, coming to the case that we published in Burundi, which was the first case in my hospital, one of the first cases in the country. This was a 40-year-old patient who was brought to emergency in our hospital with 1 week of fevers, body weakness, and genital lesions. So this patient, when she was brought to the emergency, was some blood workup was done, and they found that she was HIV positive. So she was admitted, hospitalized in internal medicine as a patient with advanced HIV, and I was called to review the lesions that she was having on her skin. So I immediately suspected Mpox after seeing the lesions and called the national lab to come and test the patient while she was already taken to isolation. So as you can see in the picture, she was having mainly ulcerated pustules. Some were already ulcerating and others were just having umbilication, but they were very painful, especially in the mucosa, the oral and the genital mucosa. So investigation were done, showing high white blood cells with predominance of neutrophils and hemoglobin of 6. Unfortunately, we couldn't do the CD4 count and the viral load because of no availability of reagent, but the national lab confirmed the following day that the patient was having Mpox. So we started immediately treating her symptomatically. So we started her, since she was already having signs of bacterial infection, started her antibiotics, started with ceftriaxone, which was not really responding. And then we moved to levofloxacin, and the wound care was mainly done with potassium permanganate and topical antibiotics such as mepirocin, and we gave something for the pain as well. Since she was already having oral candidiasis, we started her on cystatin. We didn't start her on antiviral, but we gave cotrimoxazole. So the patient developed, a few weeks later, she developed ulcerations and necrosis in the center of the ulcers and full smelling lesions. Some of them were pustules that were coalescing into bullae. So we started soaking the lesions with vinegar and applying topical antibiotics. And then this is how she looked after 3 weeks of doing that. So it responded very well. And we gave, as I mentioned before, systemic antibiotics. We started with ceftriaxone, which wasn't helping, and moved to levofloxacin. And 2 weeks later, the patient was healing well and was discharged after staying in the hospital for 2 months. Yeah, these are the pictures when she came to us a month after being discharged. She was just having hyperpigmented post-inflammatory lesions. So now coming to what has been seen in other countries, we have here a report from Nigeria when in the early outbreak in Nigeria, which was in 2019. They also observed the same thing. So patients with HIV and Mpox tend to stay longer hospitalized, and also the duration of the disease is longer compared to immunocompetent patients with higher chances of having secondary bacterial infection and atypical lesions, and as well genital ulcers. Now, when it comes to the CDC report in the US in 2022, patients who were having Mpox co-infection with HIV were hospitalized for longer, prolonged disease with complications such as death. And as you can see, the lesions look atypical as well. And this was mainly associated with low CD4 count in those patients, meaning advanced HIV. So yeah, most of the complications were dermatological, respiratory, bacterial infections, we say, but also genitourinary complication. And this was associated with either higher viral loads of the HIV or CD4, lower CD4 counts. And what else was seen apart from death was being hospitalized in intensive care in patients who were having lower CD4 and higher viral load, and also a prolonged period of hospitalization. So now coming to management of Mpox lesions in immunosuppressed patients. So I advise you if you want to look at this properly, to go to the AAD Mpox registry, where there's a whole page that focuses on wound care in this patient, because this is very important. But what I want you to remain with is and that you should know that it's very important to diagnose carefully and assess the risk of co-infection. And also what we focus on when we are doing wound care is to keep them, to do a gentle cleaning, not rough, and also to keep the wound moisture. So what we usually do, and like, for example, if I give an example, in Burundi, we use permanganate potassium for the cleaning of the wounds, and also we can just use Vaseline or Vaseline gauze on the ulcers for a very quick healing. And we avoid to use antimicrobial when they are not necessary, when there is no signs of bacterial infection. And they also mentioned in that registry that in severe cases, we may need to involve specialists such as surgeons as well. And STI screening is very important. And in this patient, Mpox patient, we need to screen not only for HIV, but also for syphilis, and give antivirals when necessary. So when it comes now to the usage or the role of tecovirimat as management of Mpox, as you may have heard about it in many discussions. So some researchers do support the efficacy and safety of using tecovirimat for management of Mpox, such as as an example of this publication. But when it comes to clinical trials, randomized clinical trials, some of them shows that there is no big difference in either the duration of the lesions when tecovirimat is being used. And also there are some literatures that tell us that we should be conscious when it comes to using it, because there are some emerging resistance of tecovirimat. So overall, it is recommended to be used in high-risk patients, such as in HIV, or patients who are hospitalized for any other conditions as a confection with Mpox. But more trials are needed to really support the usage of tecovirimat as management. But as said, it is recommended to use it in advanced HIV or pregnant patients or immunosuppressed. And also the early initiation could be more effective. And also it is generally well related and associated with very few or none side effects or a drug interaction. So as a take-home message, what I want to say is that Mpox is not over. We still need to do strong surveillance for this. And also, Mpox severity mirrors immune status. As you saw in this presentation, when there's the co-infection with HIV, the duration of hospitalization is longer, and the lesions persist longer. We still need to strengthen surveillance and laboratory capacities, because especially in Africa, we still have places where the Mpox cannot be diagnosed on time to be treated on time. And also supporting, initiating supportive wound care is very early is very important, especially when it's in immunosuppressed patients. Tecovirimat is reserved for severe high-risk Mpox with possible benefit, but inconclusive trial evidence and a need of cautious is needed. Sorry. So thank you for listening to me. I want to acknowledge the hospital administration that has been very supportive in treating patients with Mpox in the hospital, and also I will acknowledge the help from Professor Esther Freeman in writing and Professor Wende from Ethiopia in writing the case that we published from Burundi. Thank you very much. If there is any question, I'm happy to take them. Thank you.